Perfect. So hi everyone. I'm going to present just a bit of an overview of a project that I worked on a couple of months back now. But what we were doing was estimating the economic impact of achieving HPV vaccination and cervical screening targets in London. Just a bit about me. So I am a health economist. I work at the Health Economics unit. We are similar to the strategy unit where we're housed, or our home is at the CSU at the moment. And we are a team of health economists, analysts, evidence reviewers, and service delivery and support to Cummins team as well. And we basically deliver services around anything related to economics, so economic evaluation, economic modelling, resource allocation, decision support type projects as well. And then we also do a lot around population health and modelling and analytics, and lots of various and interesting projects. Before I was a health economist, I worked as an analyst as well. So I worked kind of in on national clinical audit programs first, and then I moved into NHS commissioning, worked in North East England for a few years, and did more studies and stuff, and then decided to move into health economics. So yeah, I will get started. So I'll do a very short intro to health economics as well today before presenting the project, just as a bit conscious that maybe people may not necessarily be familiar with some of the terms that I will be using throughout. So just thought a very short intro might be useful, and then I'll jump straight into presenting the project as well. So what is economics? So broadly speaking, I suppose economics is studies, I suppose, how individuals, governments, various sectors, and society as a whole allocate resources to meet the needs and wants of individuals or populations. In economics, we have this concept of scarcity, which is important, I suppose, one of the most important principles, especially when they get on to talking about health economics. So basically what that means is that we've got unlimited wants, but our resources are constrained. And then this often leads to scarcity and what's known as the economic problem. So the economic problem is essentially that conflict between limited resources and endless wants or needs. So as an individual, we may want to go on lots of different holidays and lots of different trips this summer, but we might not necessarily have the time, so that would be a resource, or the budget to do all the things we want to do. So that leads to kind of this concept of scarcity. And when we're faced with scarcity of resources, we have to make a choice about what we want to do. We might have to choose between where to go on our holidays, how much time we're going to spend in one place or another. And we might need to decide, I can't remember what the from where is now off the top of my head. I had a nice example of that. But yes, it's all about making choices, really. But when we make a choice, there's inevitably going to be an opportunity cost. And this is another really important concept in economics. So opportunity cost is benefit foregone from choosing one option over another. So if you choose to go to Glastonbury over another festival, the opportunity cost is the benefit that you would have gotten had you made your other choice and gone elsewhere, basically. So in terms of health economics, if economics is concerned with how best allocate scarce resources to satisfy wants or needs, health economics is slightly different. It's concerned with how best to allocate scarce resource to improve or maximize the population's health. In health economics, we're also faced with the economic problem, and also opportunity cost. So we know there are finite resources available. I think that this is much more of an issue at the moment. It's clear that the government doesn't have endless funds to deal with all the challenges facing the NHS and fund all that's been promised in the 10-year plan. But yeah, so basically the resources are finite, and policymakers and commissioners and everyone have to make decisions about how to make choices about how best to allocate resources to maximise the population health. But again, we're faced with scarcity, which means they then have to make a choice about what should be produced, what should be delivered, how it should be produced or delivered, and who should receive healthcare as well. So this is a picture of my team. I'm actually not in this picture because I was unwell that day, but I feel like if I was there, I would be standing here. Seems like there's a nice space in the photo for me. I was thinking about superimposing one for today, but I didn't in the end. So I suppose the reason I put this here is just to talk about kind of what's the role of a health economist. And our role, as we would probably describe it, is to generate evidence to help decision makers when they're trying to make those choices about how best to allocate resources. And there are various ways in which we do this. And I will talk about kind of one of the key functions or the things that we do briefly, which is economic evaluation, which is a really useful approach for assessing the impact of different interventions or models of care, or whatever it may be, or new ways of working. So economic evaluation helps us answer questions around whether or not an intervention is a good use of resources. It's defined as the process of comparing the costs and consequences of different healthcare interventions or programs to inform decision making. And what it basically involves is the comparison of the costs and outcomes of two different options. So it could be one intervention and a comparator, which may be business as usual. In the case of the project I'm going to present in a minute, the intervention was investing in ways to increase screening and vaccination, and the comparator was just assuming that the current situation stays the same. In our toolbox for economic evaluation, we've got lots of, there's a number of different approaches that we would select. For cost utility analysis, this helps us answer questions around which intervention provides the most health benefit for the money that's being spent. The unit of measure that you would report if you do this type of analysis is an incremental cost effectiveness ratio, specifically a cost per quality adjusted life year. In terms of cost effectiveness analysis, this would help us answer questions around which intervention achieves kind of the greatest impact at the lowest cost. So we may describe that impact or outcome of interest as admissions avoided, for example. And the unit of measure for this type of analysis, again, would be an ICER, but it would be cost per admission avoided, for example. The next one here, cost benefit analysis. This type of analysis can be used to answer questions around, if we're trying to figure out which intervention or which model of care delivers the highest financial return. And the unit of measure for this is kind of a net monetary benefit or net present value type measure. The key thing in a cost benefit analysis is it assigns a monetary value to benefits and compares that to costs, basically. The next one, a cost consequence analysis, is a useful one when you're analysing for where you may have various stakeholders who are interested in the results. So you might be interested in, you might use this when you're trying to answer questions around which costs and outcomes of this intervention, or how do a specific set of costs and outcomes differ for one intervention compared to another. So for example, if you're doing an evaluation of a behavior change program at the moment that's implemented within a trust, so that the trust is interested in specific measures, but there is also a plan to try and get it rolled out at a system level. But the measures at each of these levels, the measures of interest of the decision maker differ. So in this context, a cost consequence analysis is useful. And then lastly, we have a budget impact analysis. And this is, you would kind of do this type of analysis if you were looking to answer questions around the financial impact of adopting a new intervention or implementing a new model of care or whatever it may be. But it's just a comparison of costs. It reports the net budget impact. That is a very quick, brief intro to health economics, mainly kind of just in the context of what I'm going to present on next. So I will leave it there. I won't take questions, but if anybody has questions at the end or they want to discuss or learn more, feel free to get in touch after the call as well. I'm just going to drink some water before I jump to the next section. So I will now present an overview of kind of this project. I'll give some background to why this is an important topic and the context of what we were asked to do, and also what we did and the results as well. So why is this important? Why is cervical cancer important? So it's a highly prevalent disease in women. Each year there are around 3,300 cases diagnosed across the UK, and there are around 850 deaths as well. So 850 people die from cervical cancer each year in the UK. On top of that, it comes at a significant cost to patients, the NHS and wider society. Last year or the year before, the Office of Health Economics estimated the lifetime cost to be just over £2,000 per person, £200,000 per person, so £210,000 per person. It's the lifetime cost of cervical cancer. In 2020, the World Health Organization launched a strategy calling for the elimination of cervical cancer by 2040. So by that, they wanted to achieve kind of an instance of 4 cases per 100,000 population by 2040. In 2023, the NHS set its own ambition, aligning with the World Health Organization Global Initiative. In response to the NHS England's strategic aim, at the NHS London region established its own elimination strategy. They had three aims. One was around vaccination screening, and the third was around treatment. I'm just summarising the vaccination screening here because that's what we were including in our modelling. So the first thing they wanted to do was prevent cases of cervical cancer through enhanced vaccination. So they wanted to basically, they're implementing a set of strategies, and by implementing those, they hope that by 2030, 90% of school-aged boys and girls will be fully vaccinated with HPV vaccination by the age of 15. And in addition to that, they also wanted to increase cervical screening. And again, they were planning to introduce a series of initiatives or strategies to increase screening coverage to 70% for women aged between 25 and 65 years. And they hoped then that by doing this, they would eliminate cervical cancer by 2040. So these were kind of the set of initiatives that they planned to introduce. We weren't evaluating the impact of these specific interventions or initiatives. We were doing, our evaluation was focused on the potential impact of the value of the investment in achieving kind of these targets, and then also eliminating cervical cancer. Yeah, that's all saying that for now. So basically what NHS London wanted to do was make the case for greater funding to be able to implement these interventions. So to help make the case for additional funding, we were commissioned to develop an economic model to estimate the value of investing in these strategies to increase the coverage rates from a healthcare and wider societal perspective. I just thought I'd just spend a moment on perspective because I think it's an important concept in health economic modelling. So the perspective of any analysis basically determines which costs and benefits are included, what the key outcomes of interest are, and also the scope of the evaluation. So the perspective may be from an individual patient, a health system, or even a smaller provider level, or a societal perspective, which kind of just takes account of the impact on the patient, the health system, and includes other factors like productivity losses as well. So the approach that we took was to combine cost benefit and cost utility analysis. The cost benefit analysis. For consideration, Isaac.
You've muted yourself, Lisa.
Yes, I was about to say that. Lisa, we can't hear you. Lisa?
How did I mute myself?
I don't know. I don't know. Maybe somebody was trying to mute our friend who was talking, and it wasn't me. It wasn't me, and they muted you. But anyway, you're back in the room. You're not moving for me, but I think that's as long as I can hear you. That's the main thing. So we might have just missed 10 seconds of you as you switch screens.
Cool. Will I start? Will I just go from here?
Yes, that looks good. Yes.
Cool. I thought it was my partner's laptop that was making noise, but then but anyway, it was somebody else talking. Cool. So we combined cost benefit and cost utility analysis. The CBA.
I think Lisa, one second. I think your screen is frozen. Your camera is frozen, I think.
Oh well, I don't think I can do anything about that, can I?
No, I think as long as we can hear, can everybody don't all shout at once. No, as long as we can hear. See, when my camera freezes, my face is all sort of wonky and weird, but you look lovely, so it's absolutely fine, and we can hear you perfectly. So do carry on. Lisa, I can't hear you now. Are you there, Lisa? No, I can't hear you at the moment, Lisa. That is bizarre, isn't it? Is it not? Someone's put something in the chat. Oh, it's Lisa. No, I can't do anything to mute or unmute you, Lisa. It doesn't look like you're muted. you're still here. I can still see your screen, but I think, who thinks she's going to go and come back again? Let's see if we can get Lisa back in the room. And while she's gone, let's talk about something really fun, like the 10-year health plan. I've got no takers. I'm amazed. Simon, have a taker.
Yeah, no, well, I wanted to talk about something tangential to the side of it, which is
Okay.
that has anyone else tried using AI's new, well, I'm looking at Gemini specifically. Have they used their audio overview functionality now?
So AI's Gen or what was it called again? Audio
Overview. So
overview.
what it does now is it can take
Okay.
like large chunks of text and turn them into a podcast.
Ah, right, okay. I personally no. I'm very interested in AI and its capacity to change the world. But there are some very specific things that you can do with it which are very useful. I do know that. I've got a meeting this afternoon in the strategy unit, and there must be similar meetings happening everywhere. While Lisa's just getting back into the room, about what are our plans for AI? What are our strategies? What can we do? What can't we do? What am I going to get the sack for? What's safe? What's not? So I think everyone's going to get, particularly that last one. No one wants that.
But my reason being that
Yeah.
I ran the 10-year plan through that, and it was
Oh,
quite
right, okay.
an interesting way to take what was a dry document and
You brought it to life.
brought it to life with a podcast, or a digitally
Ah,
generated one.
okay.
It was an hour long, but it
yeah.
was better than sitting there for an hour reading the dry document.
I tell you what, I haven't read it thoroughly. It's 168 pages, and I have looked at people's reviews and things like that. So you can, if you share that with me, email me, and I can share it with others as well if they find that useful. Yeah, thanks for that. It's sometimes these things are, I mean, it's quite complicated, and there's lots of visions and stuff, and all sorts of great things in there. But it's big, and there's a lot of trying to pull it all together, and we're certainly lacking at how to do it. I'm not saying your podcast will address that bit because it's not in there, but that'd be really useful. Thank you very much. Okay, well, I definitely think that Lisa's back in the room. Lisa, are you there?
I am. Can you hear me and see me?
I can. Oh, there you are. I can hear you beautifully, and not only can I see you, but you're moving as well. So we've got the moving version of Lisa. So John, you can go back to your presentation, Lisa.
Cool. My laptop did sound like it was about to tip off, and shit.
Naughty laptop.
Yeah, I wonder if I should put my camera up, but let's see how we go. I can always turn it off.
Okay.
Maybe I can just turn it off actually, because you don't need to see me at all. Now I just, do you know what? I'll leave it on because I have to navigate again between screens. So we combined a cost benefit analysis and a utility analysis. The CBA demonstrated the broader impact to the population of London, kind of from that societal perspective. And the COA provided evidence of the value of preventing health loss, which was measured using the quality loss avoided. This is just a bit of an overview of the modelling approach. I won't go into lots of detail here. The decision problem, as we defined it, was kind of what's the potential return on investing in eliminating cervical cancer by increasing HPV vaccination and screening coverage. The approach I've already mentioned. The model type, we built a multi-year decision tree model. We developed the tool in Excel and was an adaptable scenario-based modeling tool so that the end users could vary key parameters. Data, evidence, and assumptions were drawn from various sources. So we took clinical, epidemiological, and economic evidence from the literature. We used local and national data where we could get it. And then we also used cost data, for example, from NHS cost collections as well. Because it was an assumptions-based model, we involved stakeholders as well throughout who provide kind of validation of the assumptions and the estimates that we were using. I think that's all I'll say on that for now. I can take questions if anyone has them. The model structure, this is a very simplified version, but basically we started off with people eligible for screening. We split the population first by age cohorts, so the 25 to 49 and then 50 to 64. We then split that into screening status, so whether or not somebody was up to date and outside of this, not due to be screened in the year, somebody who was up to date but due to be screened each year, those who were lapsed or never screened, and the repeat screen population. So these would be people who had kind of a negative test result or had a colposcopy but didn't necessarily have cervical cancer, so who needed to come back for further testing. So so then if you needed to be invited for screening for whatever reason, you'd be invited. A HPV test would be performed. If that was negative, you'd go back to routine recall. So you'd be invited back in 3 or 5 years, depending on your age. If it was negative, that would go for further testing. Oh no, sorry, if your HPV, if your test was positive, then that will go for further testing. If your test is negative at this point, you'd have a repeat screen the next year just to make sure that there's nothing. This was just to kind of keep an eye on you just in case there is something that wasn't picked up. If your cytology is positive, then you would have a colposcopy. Following colposcopy, you may or may not have a biopsy, and then kind of ending here, you may have a diagnosis of cervical cancer or CIN, which is the cell. You may have cell abnormalities, which then go on to cervical cancer. As I said, it was a multi-year decision tree model, and women enter and leave the model each year. I'm not going to go into this in detail, but this slide and the next slide just kind of highlights the complexity of the decision tree. We also had to account as well for the impact of the vaccine. So we kind of ended up with, there probably was 8 decision trees to model the potential eventualities and the different cohorts and the different population as well. Yeah, we'll talk about that now. Let me take, yeah. So in terms of costs and benefits, so in terms of costs, we included the investment package that was required to achieve these interventions. To implement the interventions that were aimed at achieving the targets. Resource use associated with vaccination, I suppose resource use and delivery of various programs and diagnosis and everything. So it covered any costs associated with vaccination, screening, diagnosis, and treatment. We also included productivity loss associated with mortality, morbidity, and also informal care. On the other side, in terms of benefits, we included clinical outcomes, so cervical cancer and CIN incidents, resource use avoided, health gain, which we define as quality loss avoided, and productivity loss avoided as well. In terms of key findings, we found that increasing vaccination and screening coverage reduces cervical cancer incidence, surprise, surprise, and also that there's a cost to preventing and treating cervical cancer, but investing in prevention pays off over time and it offers greater health benefit at a lower cost. So the results I'm going to present here are for 2 different scenarios. I forgot to say actually the model that we built, we applied and used conservative estimates of parameter values throughout to avoid, I suppose, overestimating the impact. We felt more comfortable underestimating the impact than overestimating. So the base case, or the best case scenario one, the green one, and we assumed that HPV vaccination screening rates, those target rates of 90% for the vaccination and 70% for screening, were achieved. Whereas in scenario two, we assumed that the current coverage rates would just remain constant over time. So what we found, the results of this scenario, this modeling output showed, was that incidence was going to decrease under both scenarios, but the reduction was greater under scenario one. And also in scenario one, there were fewer cervical cancer cases over time as well, and with the greatest reduction in those earlier stage diagnoses. In this output, it looks like the NHS England elimination target of less than 4 cases per 100,000 would not be achieved by 2040. But just to note that, again, we did apply kind of conservative assumptions, especially around vaccination coverage, because we didn't have data on the number of people vaccinated through catch-up programs, for example, and we also didn't have. We also just used those who had a full coverage, so the 2 or 3 dose, in historical data rather than those who might have had a partial dose. In terms of the cost of preventing and treating cervical cancer, both scenarios demonstrate a net loss to the NHS and wider society. Scenario one, it was 1.53 billion, and in scenario two, it was 1.65 billion. This loss makes sense because we were including like the cost of screening, the cost of vaccination, treatment costs, and the societal burden as well. So there was lots of factors flowing to this. But by achieving the targets, the model estimated the projected loss avoided over the duration of the model could be in the region of 113 million, or just over 4.5 million per year. This graph shows the difference in costs and monetizable benefits between both scenarios. This graph, sorry. And you can see here the kind of upfront costs associated with investing in screening vaccination. But then these actually taper off over time and then actually become savings, I suppose, as time progresses. And then you have or losses avoided. And then these are your benefits which accumulate throughout the duration of the model. But investing in prevention pays off over time. I did this slide. And as well, it offers greater health benefit at a lower cost. So the difference in costs between scenario one and scenario two was almost 34 million. And the difference in quality loss avoided was almost 6,500 life years, quality adjusted life years. And this gave us a cost per quality loss avoided of negative £3,000 almost. So the intervention is less costly and more effective. So it makes sense from an economic perspective to invest, I suppose. Just to note that these numbers, the cost difference includes costs to the NHS, but also the costs from that societal perspective. I didn't include it here because I ran out of time, but if you exclude the societal costs, the costs to the NHS, the difference in cost is actually higher in scenario one. So this becomes positive. So in that case, the your ISA would actually be sitting up here in this quadrant, because the difference in qualities was the same, but it's more costly now. Like from memory, I think it was about £5,000 per cost per quality loss avoided. So still technically it would be cost effectiveness. It would still be cost effective from that kind of nice acceptable value of affordability, I suppose, that 20 to 30,000 pound range. Just a quick note on the change in the ISA over time. So this graph just basically shows how that our ISA changes over time. Initially, it's very high, again, reflecting the cost of the upfront investment in prevention programs, because it takes some time for the benefits to be realized. But by 2030, the investment becomes cost effective each year as the cost per quality loss avoided falls below the nice willingness to pay thresholds, which is about 20 to 30, £20,000 worth, £30,000. Just to highlight some limitations, this was a simplified version of complex pathway, and before we decided on the modelling method and the underlying model structure, we did do a review of the literature, and if we had loads of time and loads of budget for this project, you may want to consider like a complex mathematical model to account for like the spread of HPV in the population, the impact of screening, and the impact of vaccination and how they interact together. But the nature of our roles generally means that and especially as NHS economists, we have a short period of time to deliver a project, and we don't have lots of budget because the NHS doesn't have lots of money. So we're always faced with that kind of decision around how do we simplify this, but also account for complexity of the pathway while giving the decision maker the evidence and information they may need to make a decision in the short term. Also to note that the true effect of the vaccine is underestimated, because the HPV vaccine protects against other cancers, and based on current evidence. Oh wait, no, sorry, I'm jumping ahead. So the true effect of the vaccine is underestimated. I think I mentioned this already as well, but just to add that we don't account for the impact of herd immunity and transition dynamics of population. And then the third point is that we focus only on cervical cancer, but HPV related cancers, there are other HPV related cancers that also benefit from the having the vaccine. And in the literature, another study had estimated that 80% of the total benefit of the HPV vaccine was associated with cervical cancer, whereas around 20% was attributable to the other cancers affected by HPV. So those kind of health benefits, potential cost savings, are likely actually to be higher if we had taken account of all the impact on the other cancers. And lastly, this is a population level model, so we don't account for differences across the groups of the population. I think that's all I'll say for now, but happy to take questions. And thanks for listening.
Thank you, Lisa. That was a really nice run through, and you've made it sound very sort of simple. But of course, undertaking the actual project, I'm sure, was not quite so simple, because you're dealing with people, you're dealing with data, and you're dealing with lots of other sort of dimensions as well. So there's one question on Menti. I don't think there's anything in the chat, and it was really. I won't share my screen, there's just one question, but it's really around, were there any other sort of studies that had the, similar results, or did you not, in our literature research, did you not find any sort of similar studies that you were able to sort of draw on?
Yeah, there's actually a big body of research on the impact of screening and vaccination that we would have referenced. I suppose the most closely related one to what we were doing, because we were kind of taking that societal perspective, was that Office of Health Economics project I've mentioned at the start. So at the end is when we were kind of getting our numbers out, I did some crude analysis to kind of compare that cost per person at an individual level, and they were similar really in the end. So that was reassuring. Yeah, and we would have used a lot what was in the literature around kind of relative risk of getting HP or getting cervical cancer or SIN if you've had screening or no screening, if you've been screened and haven't had a HPV vaccination. So that's how we counted for those effects.
Okay. So you haven't got the screen up now, and I was trying to understand the results. And so apologies if this is the question or the answer. The question is wrong. the answer won't be wrong. I mean, you'll give me the answer. The answer will be right. So it's just understanding. I think the benefits were more stark when you're including the wider societal benefits and less beneficial. So I'm probably using the wrong terms, but when you were just looking at NHS.
Yeah, I don't have this slide here, and I probably should have popped it in, but the difference in costs, like to the NHS, so taking those costs associated with vaccination, screening, treatment, diagnosis and treatment, when we factored in all of them, the difference really was negligible in terms of like the total cost. There was a slightly higher cost in scenario 2, and that cost was mostly due to the increase in resources needed to increase the vaccination and screening coverage rates. Like around screening, for example, you're going to have to screen more people, and you're going to have more people going through that diagnostic part of the pathway as well. And I suppose the key driver of reducing the incidence of cervical cancer in the long term is the vaccination. And if we extended the duration of the model, I think that cost then you'd start to see the costs deviate in the right direction.
Okay.
Does that answer your question?
Yes, it does. Yes, it does. Yes, thank you. And we've got Simon. Simon's got his hand up. You got a question, Simon?
Yeah, so you've proven the economic case now. What happens next? Who's going to be actioning all of it?
So this was done up for the NHS London region. So when we last spoke to them, when we shared the results, they had said that it had been very useful in supporting resource allocation decisions locally. But I don't know whether or not the decision was made, because I would say probably not long afterwards, all the announcements around the changes to the NHS were announced. So I'm not too sure if they got the size of the budget they got, I suppose, to implement their strategic program. But we're going to be working with another region as well now. Well, possibly to basically redo this for another region for the same purposes.
I was going to say sorry to hear that, but it does look like you've delivered very well. So at least it was done in time.
Yeah, so you did your job, Lisa, and think about just Simon's comments when you disappeared and came back, all refreshed. We were talking about the 10-year plan, because that's what we all dream about these days, isn't it? And the emphasis on prevention as well. So I'm very hopeful that this is just basically building that bank of evidence that people are able to sort of now tap into. Might be a delay, but there's a sort of tap into in the future, so that we can fulfill those plans, and they're good. It's good news, isn't it? The three shifts that they're talking about. So the shifting from hospital to community is obviously a key one, and that's brand new, isn't it? I mean, sorry, I'm not trying to be sarcastic, but it has been around for a few decades, much like myself. But there's some real positives in there, which might need a few pound signs attached to them as well. But we've already mentioned sort of analog to digital as well, because we've mentioned IA, so we've ticked that, and obviously this is about the prevention dimension as well, which is really, really important. And one that public health, my ex-public health colleagues and all sorts of people will be very, very interested to see how they can contribute to that as well. So thank you again, Lisa, for going through that with us, and I hope it has the desired impact. But it's not going to go away. The evidence is there. It can be tapped into in the future and be built upon. So I'm just going to share my screen again. You don't have to do anything, because I'll take it about. Look, you got applause left, right, and centre, Lisa. You should be very proud.
Thanks for having me again.
Oh, absolute pleasure. You're welcome back any time. So I'll just go back to Menti, so I can just sort of let people know what's happening in the next few huddles. So we've got. It's not the next one. These aren't in order. I should put them in order. But we do have Chris Bealey and team are going to be presenting the strategy in a new hospital program, demand and capacity model, and that will be coming up soon. I think it's actually maybe early September for that one. I will start to introduce key speakers and content for Hacker 2025 as we get them confirmed. We will be calling for abstracts very soon. So the Hacker 2025, as you might know already, is in December. So we're delighted that we're able to have Hacker 2025. It's online on the 3rd and 4th of December, and we'll be calling for abstracts very soon. It might feature the 10-year plan. I'm sure it will to some degree. I'll just flick through to the last one, which is actually the next huddle is with Fraser Batty and an analyst from the King's Fund. If Fraser's watching and it isn't the King's Fund and it was the Health Foundation, apologies, I may have got that mixed up. But Fraser's done some work. I did a project around how to determine whether analysis is good quality. And he's interviewed lots of senior analysts and some really great findings that has come out of that, and he's going to be talking through that. He's also done a blog which I might share with you when I email you about, to remind you to come and join in that session. And finally, actually that is finally, is it? No, obviously it's not final, because there are some training opportunities coming up. I already mentioned the Professor Mohammed's reporting, the understanding and reporting of hospital mortality statistics. We're going to have some new dates for that, because that was incredibly popular. We had 180 people register for the online session, and well over 100 came to the actual session itself. We don't record them. It's not suitable for recording, so please do look out for those and register on those if you're interested in hospital mortality statistics, or breaking down statistics in general, because there's some really good, more than tips actually, some helps to explain how you can actually understand statistics better and what you're actually measuring. That's really important, isn't it? We have look out for the AFA fortnightly lunch and learn sessions. There's some really good content coming up there, and as I've mentioned, Hacker is there too, and there are many more to come, because we are revisiting our training program, and hopefully we're going to be able to provide more of that for free. So I will stop sharing my screen. I'm delighted with myself that we are 1 minute before time, and I will thank you again, Lisa, for coming. Enjoy Cork and its more pleasant and comfortable environments. Stay cool, everybody else. I'm just going about to email Simon to tell him to send me that 10-year plan blog, and I'll see everybody in 2 weeks. Looking forward to it already. Okay, bye for now. Enjoy the rest of your days.
Bye.